This is Advanced PHK Theory 2, Unit 11, Part 2, toxidromes. This is the first part of the toxidromes talk. So when I talk about toxidromes, I'll be talking in mostly in broad strokes about categories of drugs, not so much individual drugs. So, if I don't mention bath salts, for example, I'm covering it off in stimulants section or in the sympathomimetic section. So, there are new drugs, new combinations of street drugs that come out all the time. But if you understand the basic toxicology of, what's a sedative, what's a depressant, what's a stimulant, it's just a matter of looking up this new street drug and getting familiar with it. Because you could do a whole day on individual street drugs and talk about the various names they come under as well. So the poisons most often associated with fatalities in adults include the antidepressants, probably most commonly anticholinergics, and there are certain antidepressants that have an anticholinergic component to it. Narcotics, sedative hypnotic stimulants, or the sympathomimetics, cardiovascular drugs, and then others, but those are the main ones. So let's talk a little bit about antidepressant overdose. We don't see as many deaths from antidepressant overdose anymore because there are very few patients on the tricyclics. The bicyclics, the serotonin reuptake inhibitors, are significantly less toxic than the TCAs were. So the cyclic depressants, the bicyclic antidepressants, which are the newer ones, the SSRIs or the inhibitors, for example, then there are the TCAs, which tend to be fairly lethal. And so common uses include major depression, enuresis, which is basically involuntary urination. Usually, when we talk about enuresis, we're usually not to incontinence in the elderly so much, but bedwetting at night in kids. And so sometimes you'll see kids on TCAs like amitriptyline. You'll see adults on amitriptyline often for chronic pain, the classic fibromyalgias and neuralgic type of pain. TCAs are also used for OCD and for attention deficit hyperactive disorder, for phobias and separation anxiety in pediatric population. In adults, it's used to treat neuralgic pain, chronic pain, and sometimes for migraine prophylaxis. I should also mention, just out of interest, Flexeril is a muscle relaxant. The other name for that is cyclobenzaprine, and I didn't know anything about cyclobenzaprine until I had a guy who overdosed on it, and so we got the call for an overdose on Flexeril, and I looked it up, and I couldn't see. I didn't get a chance to look at it in detail, but I thought, oh, it's a muscle relaxant. What's the worst thing that can happen to this guy? Just be relaxed. But he had swallowed a whole bottle of Flexeril in front of his wife and drank some beer with it. And when we got there, he was a GCS of 14, likely from the alcohol. And we put him in the stair chair. We carried him downstairs. By the time we got to the ambulance, he was a GCS of 3. And we were literally 4 blocks from the hospital. And, when we loaded him into the ambulance, and he went from being slightly responsive to completely unresponsive. At first I thought, this is not real, this is not happening. And I did a sternal rub, there was no response. I did a jaw thrust, and that's when I knew he was truly unconscious. His jaw was pretty flaccid, and I stuck an OPA in, I started BVMing him, and I told my partner we had to upgrade us to a CTAS-1. Thought about intubating him, but we were so close, and anyway, we got into the ER. They intubated him, and he was on a ventilator for over a week. So I looked up the drug again and learned that chemically cyclobenzaprine or Flexeril is very similar chemically to tricyclics, and so it was like a TCA overdose. So anyway, just thought that was interesting. So TCAs, the tox effects of tricyclics, are the result of 4 main pharmacological properties. So 1, the inhibition of norepinephrine and serotonin reuptake in the nerve terminals. Number 2, its anticholinergic effect. So initially with TCA overdoses, they present like anticholinergic. They're tachycardic, they're dry, they're they may exhibit a psychotic behavior or a strange affect. There's direct alpha blockade that happens that results in hypotension. So initially they may be hypertensive and tachycardic, followed by hypotension. And TCAs also has a membrane stabilizing effect on the myocardium. It blocks the cardiac myocytes' fast sodium channels. So although initially you may get this anticholinergic tachycardia, eventually the heart rate starts to slow, the QRS starts to widen, and we start to see myocardial depression and hypotension. So cardiovascular effects with really high overdoses, and over time we start to see decreased sodium influx in the fast sodium channels. That decreases the slope of phase 0 and the action potential, leads to QRS widening, impairs the cardiac conduction system. There's a decrease in myocardial contractility, profound hypotension, mostly due to the alpha blocking effects combined with the direct myocardial depressive effects. Initially there's tachycardia, palpitations, they may have chest pain, they may have hypertension followed by hypotension as a later sign, and bradycardia with widening the QRS is ominous. Now, one of the telltale signs of TCA overdose is where you see a positive R wave in AVR. So, positive R wave in AVR is tells you two things. One, you may be dealing with a TCA overdose, and two, a positive R wave in AVR is fairly predictive of seizures, particularly in TCAs like amitriptyline. So, CNS effects, there may be convulsions, decreased mental status, respiratory depression, drowsiness, and coma. Some peripheral autonomic system effects, the anticholinergic effects, include dry mouth, dry skin, urinary retention, blurred vision. Physical findings usually consistent with anticholinergic toxidromes include, again, this is typically their initial presentation, tachycardia, hypotension with orthostatus, and high temperature, altered mental status. They'll have an ileus, not that that's either here nor there for you and me. Some muscle rigidity, dry skin and mucous membranes, mydriasis, so dilated pupils. And the management for TCA overdose, obviously we support the ABCs, SpO2, O2, PPV, PRN, intubate, PRN. This is not something that's readily reversible. If you can manage the ventilations of the PVM, that's probably a good starting point until we start to treat them. Look at the ECG, look for widening of the QRS, look for that R wave in AVR. IV access, fluid resuscitation for hypotension as per our directives, fairly straightforward, and patch for sodium bicarb. Now, the primary benefit of sodium bicarbonate, remember that they have, in TCA overdose, they have sodium channel blockade. So if you're seeing hypotension and widened QRS, the primary benefit of sodium bicarbonate is not the buffering effect, it's the high sodium level in the sodium bicarbonate. It's a 3% saline solution compared to our 0.9% saline solution in the bag. And so that helps to counter the sodium channel blockade effects of TCA. And alkalinization may speed the elimination of the drug as well. Any questions about TCAs? Okay. Anticholinergic poisoning. So this results in inhibition of the cholinergic neurotransmission at the muscarinic receptors in the autonomic nervous system and central nervous system. Predominantly occurs at the peripheral postganglionic parasympathetic muscarinic receptors, so heart, salivary glands, sweat glands, GI tract, GU tract. They also, anticholinergics also block histamine receptors in the brain, and when you get, what happens when you inhibit histamine in the CNS? Your emergency medicine handbook, by the way, covers toxidromes extremely well. Sorry, Adam, I see you've got your hand raised, but that may have been up there quite some time ago. Because I only just saw it now.
Yeah, sorry, I was it was my fat fingers on the screen. I tried to hit the mute button.
Oh, yeah, no worries. Yeah, drowsiness. So yeah, when you inhibit histamine in the brain, you get drowsiness. That's why we see that with Benadryl and Gravol. Um, so some common sources of antihistamines include anti-motion sickness drugs, cold allergy and sleep medications, anti-motility drugs, antipsychotics, antispasmodics. So patients with CP, for example, or Parkinson's, TCAs also have it, and certain plants like magic mushrooms and Jimson weed. May be caused by intentional overdose or inadvertent ingestion, medical noncompliance, or geriatric polypharmacy. This is what Jimson weed looks like, and we have one of the small towns where I work. I guess not that small. Teens are really into magic mushrooms and Jimson weed, ironically. So apparently, the seeds in Jimson weed, their effects are really unpredictable. A single seed can cause euphoria and hallucinations and some really cool experiences, or it can be fatal. So not exactly a safe thing to experiment with. Anticholinergic poisoning. So the nicotinic toxidrome for that, and toxidrome is really the collection of signs and symptoms associated with a toxin. So the clinical presentation, although it can be subtle, is the mnemonic: red as a beet, blind as a bat, hot as a hare, dry as a bone, and mad as a hatter. Now, does anyone know where that comes from, that mad as a hatter thing? Yeah, it's Alice in Wonderland, but what was it that people who made hats? Yeah, that's it, Charles. Yeah, mercury toxicity from hat makers. Yeah, so they use mercury, and mercury is a neurotoxin. Now, what's the full as a flask? I don't know that one. Oh, okay. Full as a flask. I love it. Okay. So central signs are progressive, and they include anxiety, agitation, lethargy, respiratory failure, seizures, coma, death. So management for anticholinergic poisonings is largely supportive: SpO2, ECG, O2, PRN, PPV, PRN, and assess blood glucose levels, IV access for rehydration, treat seizures as we normally would as per our directives, and patch for BHP for advice if needed. Let's talk about stimulants. So common sources include cocaine, theophylline. We don't see theophylline much anymore. We used to administer theophylline to COPDers and severe asthmatics, and asthmatics used to take PO theophylline back in the 80s when I first started this career. Amphetamines, crystal meth, PCP, LSD, caffeine. So sympathomimetics means they're in a hyperadrenergic state. So hyperadrenergic is synonymous with hypermetabolic state. So cardiovascular metabolic toxicity has been attributed to catecholamine excess, and the rise in catecholamines can cause hypokalemia because it drives potassium intercellularly, so the serum levels of potassium are low, and hyperglycemia, seen in acute poisonings. maybe a respiratory alkalosis from hyperventilation, and agitation secondary to cerebral excitation. Hyperreflexia is common. The worst cases, seizures can occur. Sometimes seizures are brief, like for example with ecstasy. Kids that takes ecstasy and raves are a particularly bad spot. The ecstasy itself may not cause seizures, but these kids get hot, they get sweaty, and they're given water. So they sell water at a very exorbitant cost, by the way, and they drink lots and lots of water, and they become hyponatremic, and then they develop a dilutional hyponatremia, and that can cause seizures, and seizures are sometimes brief. Yeah. So, Charles, what's a tea overdose? Oh, okay, gotcha. Um, one of the theories behind the seizures also includes, or causes of seizures includes a cerebral vasoconstriction or cerebral vasospasm. So, sympathomimetics, example, cocaine. They get hyperthermic, they develop seizures, they may have vasospastic angina, they may actually have MIs, strokes, delirium, nausea, palpitations, diaphoresis, paranoia, anxiety, panic, intense highs, usually followed by very intense lows, and death. And it's important to remember that people who use cocaine, example, recreationally, develop heart disease very early, and we may see myocardial infarctions at very young ages. So fatal dose of cocaine is about 12.2 or 1.2 grams. Mixing alcohol with cocaine leads to cocoethylene, which has a 40 times greater affinity for cocaine receptors than cocaine alone, and increases the risk of sudden death 20-fold. So here's a cardiogram. You've seen this cardiogram before. It's in my workbook. This is a 34-year-old male cocaine user who's having an acute anterior wall MI. But when you look at this, the thing that's important to notice is the fact that his heart rate is 150, and that's unusual in a STEMI. So here's some samples of cocaine, what it looks like. And the management in general for sympathomimetics is ABCDs. Cooling measures for hyperthermia, that's really the key, especially in cocaine. The one thing that'll kill a cocaine user, a cocaine overdose or excessive cocaine, will be hyperthermia. So we need to initiate cooling measures, get them in the back of the ambulance on the stretcher, ice packs between the legs and in the armpits, a sheet irrigated with saline, that sort of thing. You may have some difficulty getting them to comply, but they'll feel really hot, and they may be receptive to that kind of treatment. SpO2, ECG, O2, PRN. O2, even if their saturations are good, their metabolic demands are going to be very, very high. So I think it would not be unreasonable to administer O2, at least by nasal prongs. We want to do a head-to-toe because they may be insensitive to pain. They may have sustained trauma, so we'll do a quick head-to-toe exam. IV access, fluids, and IV fluids will help cool the body as well. So, a patch to a BHP, because the other treatment for these guys would be sedation with benzodiazepines. So, cooling and sedation are really the two life-saving procedures for these patients: cooling and sedation. If you have someone, for example, who's on a sympathomimetic and they develop a VT, particularly cocaine again, sodium bicarb is a treatment of choice for VT. And then 12-lead ECGs, of course, and treat chest pain as per directives. And that's it for that section on toxidromes. Any questions?
Just about your, yeah, that's exactly Chris's question. Is the reason you're giving bicarb because the cause of the VT is the acidosis, or is there some other reason we're going for bicarb rather than amio or something like that?
The rationale for bicarb, if I recall, I'm just trying to recall, is the sodium load. And first of all, lidocaine would be contraindicated in VT for as a result of cocaine. Amio, just not as effective as bicarb, but the pharmacodynamics escapes me right now for bicarb in the setting of VT and stimulants. But I think it's the sodium content that's is the reason, is the rationale, because one, cocaine causes sodium channel blockade, and but initially there's tachycardia and hypermetabolic state, and okay, yeah, I'm just reading everyone else's or MJ's answers. Good.